Good morning, everyone. My name is Alison Kitson, and it is my absolute delight to be here virtually, of course, speaking to you at your Transplant Nurses Association annual conference. It's been a couple of rough years for us all, but I think we've all learned how to make connections with people, our colleagues, our families, our friends. So I know that you've had a great day yesterday, lots of really inspiring, inspirational speakers, and I'm delighted to hear today to start your Friday morning off by talking about excellence in nursing and what clinical nursing holds in the future 21st century, or what it holds for us. My name is, as I said, Alison Kitson. I'm the Vice President and Executive Dean of the College of Nursing and Health Sciences at Flinders University, and also Foundation Director of our newly formed Caring Futures Institute. I've also got a few sort of visiting professorships and visiting research associate roles. And one that keeps me coming back to the UK when I'm allowed back in is at Green Templeton College at the University of Oxford. And I'll also be telling you a bit more about the International Learning Collaborative. I do feel like a weather girl, sort of pointing to things at the screen, so hopefully I'll be able to rattle you through this presentation. Also, and I'm going to move to the other side of the screen, just want to pay thanks to colleagues, Suzanne Pearce, Dr. Suzanne Pearce, and two transplant nursing colleagues that we discovered are really expert in this. Nicole Loft, who's a nurse practitioner working in post-allogenic stem transplant at Flinders, and also Ensi Fatou Zadeh, who is one of our postgraduate students at the college, and she's actually has a background in organ donation and was actually one of the first team to work in organ donation in Iran. So I'm indebted to Nicole and Enzi for giving me some sort of specific information about transplant nursing. I suppose the image illustrates that we don't really know who's been a transplant recipient, whether they are about to donate or whether they are about to receive. We'll walk past people in the street, we'll walk past them in the primary care centres in our hospitals. We don't really know what has happened to them and their lives. And this, I think, is one of the things that I want to talk about, because just as we are totally indebted to the stellar scientific discoveries in immune responses, in how the body copes with foreign bodies and how you suppress that, how you manage it, how you curate and harvest organs. We also want to try and think about how we generate that incisive science around caring. And this is what I'm going to talk to you about. And so I want to acknowledge the team that I'm working with in our Caring Futures Institute: Beck Golly, Julie Ratcliffe, Beck Feo, Joe Archuli, Sally Robinson, Michael Lawless, Robin Clark, and Belinda Lang, an interdisciplinary team of scientists, of researchers. I would also like to acknowledge the traditional owners of the land upon which we meet, the Kaurna people, and pay my respects to elders past, present and emerging. And I would also like to acknowledge that a lot of the work that I'm going to be talking about comes from the work of the Research Institute, the Caring Futures Institute, that is really dedicated to the study of self-care and caring solutions across the lifespan. And this, as the title of my presentation illustrates, is that I'm sort of challenging you as experts in the transplant medicine and caring world to reflect and think about how you can actually begin to think about delivering patient care in a life course theory way, in a way that helps you understand care across the different lifespans. So how I'm going to, and I have to say I have an itchy nose, so apologies, I'm going to have to scratch. Lecture structure, what's the problem? So if we're talking about the future and how we're going to get ourselves ready for a future in excellence in clinical nursing, in clinical care, in person-centered care, what's stopping us from doing this now? The background to the problem, why the problem exists, talking a bit about fundamentals of care framework that we've been generating as a theoretical and a mental model, a way of actually thinking much more systematically about the care we give, and then how we're refining and testing and implementing that framework. And hopefully in this presentation I will stimulate enough conversation that you will want to contact us at the Caring Futures Institute to actually think about how you could use some of the theoretical developments, some of the hypotheses that we've been generating to help us understand how we can provide a more integrated approach to people who are going through a transplant journey and also living with the consequences of transplantations. So what's the problem? Well, from the moment we enter this world to the moment we exit it, there is one common denominator, and that's the fact that we have been cared for in a way that has enabled us to survive and hopefully thrive. Because it is such a universal construct, it's often the thing that is first mostly forgotten, and secondly assumed to be something that is a bit of based on common sense. But yet you guys know in the transplant world that our understanding of the scientific discoveries of how we had our first heart transplant only, I think it was the mid-60s, liver, kidneys, corneal grafts, stem cells, face transplants, hand transplants, the whole science around transplantation surgery and care is really on an exponential growth. The way that we can protect and save organs, the way that the exquisite surgery that is undertaken, these are the things that we have to stand in awe about. But equally, how we work with a distraught family that is about to donate an organ, how we prepare people who have been waiting for months, possibly years, for a change in their life, how we settle them in, how we help the whole family to manage it, how we help them to manage their activities of daily living, their fundamentals of care, their self-care after the donation, are all things that we as nurses and we as health professionals, as allied health, as family members really have to have a deep scientific, rigorous understanding about how we can do these things better. So whether it's at the harvesting, whether it's life after the transplant, whether it's working on a one-to-one, these are all the aspects of clinical excellence that you guys in the room will be able to have opinions about. My job is not to pretend that I know the depth, the complexity, the science around those processes. My job is to try and illustrate some of the universal constructs around caring and nursing care in particular. So we know unfortunately, from not just the narratives around COVID and long COVID, not just the issues around some of the royal commissions that we've had, some of the dreadful issues around neglect. that we cannot confidently say that we know how to consistently provide care to the people who use our health services or our aged care services or any of our caring services. We have been acculturated into a view that care is related to clinical episodic crises, episodes, and it's not seen possibly in the more holistic way that we should be thinking about it. Again, for some clients or patients, that's more acceptable than others, but if you live with a chronic disease, if you have a disability, then you know that continuity of care, integration of care are really, really important. We also know that delivery of basic, essential or fundamental care needs is often the first casualties in overwrought systems, in systems that have financial challenges. And again, we have to understand why politically, from a policy perspective, that some of these really essential human interactive or essential aspects of care get left out. You know, how come we think it's more acceptable to sort of give the drug regime rather than actually make sure that a person's oral health is properly carried out, given the risks of an infection if you're immunocompromised are as great if your oral health or your oral hygiene is not really addressed. So why are we still in this situation? Well, I think my aha moment came whenever I discovered that fundamental care delivery, or making sure that delivering care, the fundamental care, basic care, activities of living, whatever we choose to call it, it's not because we choose not to do it, or that we don't think it's important. It's just that it sort of gets left off or missed out. And that's because it's very complex to do right, to do consistently right. So it's a wicked problem rather than a traditional linear problem. So in our Western society, we've been taught how to solve problems in a logico-deductive way. That means that you think you've got a problem, you test out a few ways of solving it, and then, hey presto, you've got your solution. Nice straight line. Yet we know increasingly we're dealing with multifactorial wicked problems. Climate change is one example, COVID is another. I would be suggesting delivering fundamental care is a third key one. So why are we in this state that care, which I've argued is the most universal experience that we all have, it keeps us alive. If it's so important, then how come we've not got the science around it? How come we don't have a burgeoning evidence base to tell us how to care correctly? And how come we've still got multiple examples around the world of when care gets neglected? Well, it's not that we haven't tried to solve the problem, and certainly from a philosophical or historical background, we know that through the ages, and particularly in the Renaissance, there was a whole sort of movement in philosophical Western thinking to help people understand how they could live a good life and what does that mean for them in terms of caring for themselves. It was often an aesthetic intellectual pursuit, and certainly some of the giants, Kierkegaard, Goethe, other people like Wittgenstein, these are people who have certainly influenced nursing philosophy and the way that we think about the shift from awareness and self into caring for self and caring for others. And we know that Meyerhoff and Erik Erikson, two psychologists, were again people who tried to link the social psychological development of individuals and that awareness of caring for self and caring for others. We also know from a nursing perspective that we have a strong tradition of theories of caring, whether it's Dorothea Oram, Virginia Henderson, Carol Gilligan's feminist take on it, or Jean Watson's notion of that sort of existential shared understanding of when two people come together. These are the sorts of ideas that have shaped nursing. Equally, taking a more biopsychosocial or biomedical approach, we know that in the way that we learn how to think about interventions, very much this is very much both implicit and explicit way, using the biomedical model. Single factor causes. Illness is a simple process. People aren't responsible for their illness. So even though we now know, given the complexity and multifactorial nature of illness, that way of thinking is not appropriate, it still is the prevailing discourse, even implicitly. The more enlightened, and certainly people who will work in the transplant sort of area or in rehabilitation, know that the biopsychosocial approach is much more appropriate to the way that we think about how we manage acute episodes stacked on life experience, and then how to live with one's illness afterwards. That takes change in the teamwork, in the relationship, in the way that things are done. And equally, if you start to take a biopsychosocial approach, you also know that the caring factor is more important. Self-care, the care that you receive from other people and from professionals. But yet we know that if we say that care is a wicked problem, we know that that is going to also shape, influence, and have an impact on the way that we can actually research care, because as a universal, ubiquitous phenomenon, it's very difficult to isolate it. You need to have really sophisticated ways of researching what it is that you're trying to unravel and understand in the multiple interactions around care. So it isn't just the clinical symptom that you're looking at as a nurse or as a carer. You are looking at that plus all the other things that surround that individual's life, their care narrative, their care experience, the way that they care for themselves, the way that they are drawing on or not, as the case may be, other people in their network. So we've talked about care being a universal phenomenon. We've talked about it being a wicked problem. We've talked about it, the paradox of it being everywhere but nowhere, everybody's responsibility but nobody's responsibility, how hard it is to research it in order to develop a sound theoretical body of information that can lead to evidence-based interventions that will inform the work that people like us do. So the first stumbling block is that if we're trying to look at how we would get fundamental care right in our systems, well, you know, the first problem is that we're all using different language. So it's a Tower of Babel in terms of the different language. Does it matter? Well, possibly no, but possibly yes, so long as we agree what we're going to call things. So we've chosen fundamental care as our method of describing it, because all of the other things have got different interpretations around them. Equally, if we're not clear about what constitutes fundamental care, it means that when we as nurses or allied health or rehabilitation experts or clinicians go to assess someone's need for care, for fundamental care, so I as the nurse, the transplant nurse, talking to someone, how do I sort of work out what their self-care pattern of behavior is, what their understanding is, how they, do they know what what causes constipation or why they get chest infections or urinary tract infections. What's their integration of their health understanding or health literacy versus their care literacy? And we reckon that that dissonance causes a lot of duplication and not unnecessary duplication of work. So this was a recent study that was done in a Victorian hospitals that showed that out of an assessment process, assessing admission assessment generated, between 8 and 27 forms with up to 500 different items. That had over 2,000 data items that were universal and over 1,000 that were selective. Now, how are we going to curate or interpret all of that data? How much is duplication? How much is being used? How could we just simplify all of that so we can use it? So as I said, hopefully some of these comments that I'm making will resonate with you when you sort of are assessing, engaging, doing admissions, that you're thinking about the amount of duplication, the questions that you might want to ask and you don't have information for. Patients might be saying, well, I've already told someone about that. So how can we actually work together in a much more structured way? That is what I would call a wicked problem, because you know what? If it was a simple problem, we would have solved that a long time ago. The fact, I'm in this business 30 years, still talking about it, not for the want of trying, but just that we're all not realizing the profound nature and complexity of the problem. So we're saying the first thing is to generate consistent language, consistent definitions about what constitutes care and what constitutes fundamental care needs. And this is where we came up with the framework. The first bit of work we did was we found that in seminal nursing texts, there was quite variation in the amount of focus that nursing textbooks would give to different aspects of fundamental care delivery. You can see that over on this side, the safety, nutrition, elimination were seen as pretty universal, whereas aspects such as comfort, pain management, privacy and dignity were less consistently articulated. Now again, given that we're in a world that talks about person-centered care, we're in a world that embraces the biopsychosocial model of care, we're in a world that is encouraging consumers and people who use systems to actually talk about their experience, then you know that these things are really important. That led us on to developing our Fundamentals of Care framework, and that was generated by an international team of researchers, clinicians, leaders, educators from a range of different professional groups, mostly nursing and also consumers. And this was published in 2013, which was really about how we can reclaim and redefine fundamentals of care. So how have we been refining and testing the framework? The way that we've been analysing or developing and testing the framework has been a very structured, interprofessional, working with consumers around both checking out the framework and also testing it from existing evidence. So the original framework, as I said, was co-designed. We've further refined the central part of the framework around the nurse-patient relationship, and we've also undertaken systematic reviews of aspects of a discrete fundamental of care activities that really relate to interventions. So again, it would be interesting to see within the transplant nursing literature, research literature, whether there are aspects of fundamentals of care interventions that you've really sort of championed around engagement, building relationships, building resilience, again around self-care, because self-care is very changed with individuals who are managing transplants. So this is what we've done. This is the new framework that was refined through our Delphi study. Again, the three aspects, most important is the relationship between the carer and the person being cared for. That relationship can be as small or as wide, depending on the network and the range of people in that network. But equally, the integration of care, we see it as a whole. It's the psychosocial, physical, and relational. You just don't take a patient to the toilet, or you just don't give them their food. You have to connect with that whole experience, the joy or the sadness it will evoke, the way that you engage. And these are the things that having a more scientific approach to the delivery of care is really, really important. And then outside is the context where you deliver care, whether it's in an ICU or in the ED or in the person's home. These will all be things that will change the dynamic between the relationship and the integration of care. If you're interested in the relationship work, here are some examples of work that we've done, which really does reinforce both the inductive way that we've developed the framework or the deductive, that's testing out other sorts of evidence. So the next steps to our work, and this is what I'm hoping that in terms of our excellence for the future, is that we're going to be connecting our fundamentals of care framework with a life course perspective. So there's been a lot of interest in how people, certainly in epidemiology, in child health, in chronic disease management, in aging, there is a growing discourse around the fact that what happens in the first 2 years of your life, the first 8 years, is going to have an impact on your health history. We've taken that idea and we're arguing that what happens in your first couple of years, in your first 8 years, in the way that you were cared for, your experience of care, your ability to self-care is going to influence your ability not just to care for yourself, but for others, and not just to care for yourself when you're healthy, but equally when you are under sort of transitions or experiencing ill health. So we've put these two ideas together in a paper that was published recently in the Journal of Advanced Nursing called Towards a Unifying Caring Life Course Theory for Better Self-Care and Caring Solutions. Now again, given that people who live with a transplant need to be so acutely aware of their daily routines, keeping themselves healthy, making sure they undertake good oral hygiene, reduce infections, look out for the signs of sort of changes. You can see that this is an important aspect for us to think about. And equally, as you would know, people who have advanced or well-developed self-care capability are probably going to require less support from the care network than those who have not got that implicit skill or capability. So as we've said, we're reckoning that what happens early on in your life affects later experiences. Intrinsic and extrinsic factors affect an individual's life course. That means how you're born, what your parents' health was like versus where you live. They're going to be things that influence your ability to self-care. Transition points are, if you're in a state getting pregnant or retiring, these are going to be impactful in terms of your own resilience and self-care capability, as well as if you have something, let's say you're a transplant survivor and you fall and break a leg and then you get an infection, well, that care trajectory could totally put you off course or create a whole range of other implications that you and your family and your health team around you need to help you understand. And that means that all of the things that we take for granted, eating, drinking, going to the loo, having our dignity respected, are all moving artifacts in that whole experience of self-care, which is why we're trying to put a science around it, because you can. It just doesn't happen by accident. You can observe it, you can research it, you can make sure that it is moving in the right direction, which means that how we're starting to test the theory in the Caring Futures Institute is actually sort of trying to sort of think about a few propositions. The working hypothesis is that the proportion of self-care needs met through self-care and care from others throughout the lifespan is changing. So the needs you have are mostly met by parents or key other people at the beginning of your life. As you grow older, as you learn to self-care, then your dependence on other people is less and your ability to self-care is increased. And then there is some sort of notion that as you get older, your reliance on other people will increase. Now, again, in terms of us testing this out, we need to gather lots of stories, lots of data, lots of illustrations about how things are normalized, as you would call it, and how trajectories change. So you can see from the blue the line here that this is a sort of a hypothetical line relating to someone who has very limited self-care capacity across their lifespan, which therefore requires significant support from other people. Now, if you think of someone like Stephen Hawking, for example, he would be someone in that category. If you think of a range of people who have had situations in their lives where they no longer are independent, then their ability to live a good and fulfilling life is dependent on other people. Equally, the orange one would show someone who is working towards independence, optimal independence and self-care, and then something happens and they require support from other people. It could be that's a point in a transition, a transplantation or whatever. And then this diagram shows that, again, if you're working on this notion that a person's self-care capability and their care from others, you can identify times when the self-care capability is less than the self-care need, and the care from others is less than what is being delivered. So again, as professionals, we would be able to hypothesize or to predict from cases, from assessments, the likelihood of some of these scenarios happening. And if we can predict the likelihood, then we can stop it from happening. And my last slide in this rapid romp through the theory, and if you're interested in it, I would suggest you go and have a wee read at the document, is that care needs from other people are delivered by at least 3 different groups. From friends, relatives, people in our immediate family, that's one, and that's the majority. We know that the majority of care is done by unpaid carers. 2 are paid carers, so these would be health support workers or people who are not professionally qualified, and then the 3s are professional health and care workers. So that's people like us, nurses, allied health medics, social workers, the great army of people who, whilst we have an understanding of self-care and need from other people, we might not possibly acknowledge that we're just, as we say, the tip of the iceberg. So really, just to sort of try and whet your appetite as to how you could apply this sort of theory, this way of thinking. Here's a case study that, again, I'll just rattle through very quickly. So Mr. S, a 46-year-old carpenter, was admitted to the ICU following significant CVA. During his admission, he succumbs to his injuries and was declared brain dead. He's survived by his wife and 2 young children. Mr. S is registered for organ donation, but following the conversation with his wife, it becomes clear that she was not aware of his wishes. So if you were trying to understand and take account of this whole holistic scenario, this scenario in terms of a life course and in terms of the caring life course theory and fundamentals of care, you would know that the situation, formerly an independent person with child responsibilities, you know that his immediate family are faced with the decision of organ donation. That's going to be a surprise, an extra level of stress onto a woman who's just lost her husband, her life partner. So not only do you have the care needs for Mr. S, but you've got the care needs for his wife. And how are we going to sort of begin to unravel how those self-care needs, how those needs from care from others are going to be managed in this situation? How do we deliver a care package that actually not just is focusing on the expert clinicians, but thinking about the wider family network, the wider care network that needs to be brought in at different times to be able to manage the care transition, so that the wife of Mr. S is able to walk away from that traumatic experience in a way that helps her grieve, create closure, and actually be able to tell a story to her young children about that tragic situation that she had to experience, which is all part of her care biography. And again, I'm sure you will have experiences of when tragic situations like this are done with real sensitivity, with professionalism, with deep empathy, with great scientific intuitive understanding, and you will also have experiences when it has been less than acceptable. So again, think about the things that you know when they work well. Think about this framework and think about how we might be able to continue the dialogue between transplant nurses and how we deliver this care and the work of the Caring Futures Institute. Again, we can. That was quite a sort of challenging experience, but you know that transplantations take place in all sorts of situations. People who are extremely dependent, and others who are independent and suddenly become dependent. And these are the things that, again, the theory can articulate. And again, if you're interested in some of the work that we're doing around the difference between self-care and self-management, this, again, is a document that's just been published. So the next big challenge is, well, we're trying to make sure that, particularly in the nursing profession, that we speak up for fundamental care. We acknowledge it's the wickedness of the problem, and that we have to really be confident when we value it, talk about it, do it, own it, and research it. And it's not clinical or situation specific. It's not clinical condition specific, it is universal. So that's why it's as relevant to rehab nurses as aged care nurses, as acute care nurses, as transplant nurses. We all work in a complex health system, and what we need to do is stop the pretense that the problems that we face are straightforward, have linear solutions. We have to understand the interconnectedness, the holistic way that we need to think, the way that we need to understand and keep going back to problems, and that the way that we need to work, that we're interdependent and that we have to work together in order to solve these problems. If you're interested in any of this, we have an international group that's called an international learning collaborative that is looking at research and academic practice program. And we've also got a call out for articles in an upcoming edition of Leadership for Fundamental Care. And the final plug is, if again you're interested in any of this, we have our 2022 conference theme, Fundamental Care in Times of Crisis. And that is followed by a pilot leadership program that we're running. So again, we would love you to join. We'd love you to give us feedback on this work. And this is where you can get hold of us for any of the stuff that you heard today. Thank you so much. It's been lovely to virtually talk to you all. I hope that it has stimulated some commentary, and please make sure you contact us at Flinders. Thank you so much.